Hello, my name is Tracy Goodman. I'm the Patient Services Manager for the AF Association. Today, I'm delighted to be joined by Dr. Patrick Heck. He is a consultant cardiologist and electrophysiologist at the Royal Papworth Hospital in Cambridge. Thank you, Dr. Heck. Thank you for joining us on our Global AF Aware Week coffee morning today.
Thank you, Tracy. Sorry I couldn't be live on the day, but we can fix that next time.
Thank you. So if I may, Dr. Heck, I do have a few questions regarding ablation to ask you today. So if we would like to make a start. The first question that we've been asked is, what is ablation and who should be offered this treatment option?
Okay, well, obviously a very sensible question, and I think having an awareness of AF Week is very pertinent given the ESC this year, which is the European Society for Cardiology, which even though we've had Brexit, we still look to the European Society and contribute to them in terms of guidelines and general progress within cardiology, and they have very much updated their guideline recommendations with regards to AF management more generally, and also specifically within that, recommendations about AF ablations and which patients are suitable for it, how it should be done, etc. from all of that. And I'm guessing, given that this is an AF awareness week, most of the audience will undoubtedly have a fairly good working knowledge about AF anyway, although it's not an unreasonable thing just to recap given the updated data that we get on AF each year. And this is from the European Society, as I say, who we generally do look to. And I think it's fair to say now that AF is by far and away the most common sustained arrhythmia that's seen across the world. Technology has improved dramatically in our ability to detect it, along with knowledge about the condition, and organizations such as yourself at the Arrhythmia Alliance organizing AF awareness weeks and historically pulse checks weeks as well, which have also further improved our detection of AF. So that now there are approximately 60 million people 5 years ago that were known to have AF throughout the world. It seems that every decade or so, the incidence of AF is increasing at a quite significant rate, partly because we are living longer and sometimes not always living the most healthy lifestyles either. So it is a combination of the increased risk factors for AF, the increased longevity, and the fact that in a positive light, we are surviving other conditions that historically we might not have done. And all of this means that as a consequence, AF is becoming a very big problem, but also one we can do quite a lot about. At the moment, the AF is estimated that all of us, once we get over the age of 40, will have a 1 in 3 lifetime risk of getting AF at some point. So it will not be uncommon for you either to have AF or to know someone who has AF. Ablation is a very key step within the management of AF, but it is absolutely not the only thing that is important. And this is something we, as the doctors, have not been very good at in the last 15 years or so, but we've become a lot better at it as more clinical data has come out, and we've started to appreciate that focusing solely on ablation will never have as great an impact if we do that without addressing the other things as well. And so within the European guidelines, they've very much taken that on board and acknowledged that not only is AF an increasing burden to society, but there's also a lot that can be done both medically and non-medically to help deal with it. And nothing's quite right without a new Django or something equivalent, and this is the one that they have come up with. And they refer to care as a way to sort of help us in our remembering of what are the important factors to deal with within AF. So obviously identifying it is the first important issue. Without the identification of AF, we can't really progress anywhere further. But then we very much do have to look at the C first and foremost. So looking at the comorbidity factors that increase likelihood of AF, but also increase the symptoms that patients are going to get when they have AF as well. If we don't deal with these things in parallel to everything else, then we're not really doing the patients a very good service, because they're not going to get a good outcome with just drugs or just ablation. And that's going to require different people. It's going to require the patients themselves, primary care, cardiologists, nursing care specialists, charities, a whole raft of people getting involved. The next important thing is, of course, about the anticoagulation issue, which hopefully most patients are very clued up to. AF is a very important risk or thromboembolic events, so clots forming in the heart and showering off elsewhere. So that does need to be dealt with as well. And whilst that is important, unfortunately, that won't make any difference to any of the symptoms that people get. So then we definitely come on to the bit where I guess patients are going to be particularly interested from today's talk, and also is where I fit into things in my role generally as well. It's about how best to actually manage the arrhythmia itself with medications, etc., or with the ablations. And then finally, not just sitting on our laurels once we've done something, it's reevaluating things, going back and seeing, has our plan worked? Have the lifestyle factor modifications worked, etc. And so before we touch on AF, I'll just highlight that anyone can access this kind of data because it is in the public domain, but it's not just saying, oh, people must be healthy. There are some very specific targets that the European Society has advocated as now having a really good body of clinical evidence that these things matter. These will make a good difference to both the patient's health, but also their AF burden as well, independent often of what we do in cardiology or electrophysiology. And so being sensible about alcohol, taking lots of cardiovascular exercise, keeping weight down, losing weight if overweight, all of the things that probably we know about anyway, but they've done it in a nice itemized fashion so that people can refer back to it, and healthcare professionals can very much look at it and go, okay, it's not an airy-fairy thing, it's a target driven in a particular direction, understanding that they're not easy things to achieve, but they should be done in parallel with the ablation side of things. And so then you say, well, okay, let's talk about ablation then. So that's, I feel like that's the preamble. But when it comes on to ablation, one thing that has changed over the last few years is the question of who can have an ablation, who is suitable for an ablation. Well, I don't know what people know about ablation, but this is something that has been around from a research perspective from probably the mid to late 80s and 90s, with some pioneering work done in France in particular, where groups worked out which bits of the heart trigger AF in the vast majority of people. And then things evolved from there to say, okay, well, let's target those areas. Let's go into the heart and let's ablate those foci, those areas that set off those people's AF, and see whether that results in them having fewer episodes. As time moves on, the procedure gets refined, gets improved, it gets expanded, and it gets to the point where we are today, where we know that almost in a one-size-fits-all sort of perspective, you can approach paroxysmal AF in particular and say, right, everybody should have, when they want to go forward from the ablation, there's a particular strategy that can be adopted. It's an effective tool. And what we basically will do is go in and do the same thing in each patient, where we will selectively injure bits of the heart's electrical tissue that are known to trigger off their episodes of AF. And it's not a procedure that is aiming to cure AF, but it is a procedure that is unarguably proven to be very effective at reducing the amount of AF patients get, and so improves their quality of life, and often will enable us to reduce some of the medications that they have been prescribed to control their AF. And that also usually will result in improvement in quality of life as well. And so when talking about it, particularly in the setting of paroxysmal AF, so the intermittent form of AF, the latest guidelines have very much been reflecting on the recent evidence, reflecting on the fact that procedure has become more mainstream, more effective, and generally safer as well, to say that actually, not only do we, as we have done historically, recommend that anybody who has paroxysmal AF and is symptomatic and has tried some tablet therapy for it, and maybe that hasn't worked ideally, they for an ablation, but also nowadays, you don't have to wait for the drugs to have so-called failed necessarily. The ablation is such an effective strategy in paroxysmal AF that some, in fact, most patients should be considered for it as a first-line option, obviously taking into account other illnesses and comorbidities, etc. But this is nice data to say, actually, ablation is very effective, and we don't want to wait necessarily too long to do it in all patients. We would like to have the opportunity to have the conversation with people earlier rather than later.
Thank you. That's very good information. So there is no good age to have one. Any age is suitable.
Absolutely. I think the age is not really the thing that will determine the success or otherwise of the ablation. Age is just a number more often than not, and a lot will then depend on other comorbidities and how well the patient is. And there can be some amazing patients in their mid-80s with few other illnesses with paroxysmal intermittent AF who will get a great outcome from an ablation if that's what they want. And so age on its own is definitely not a reason not to have an ablation.
Okay.
And the overall feeling from most electrophysiologists and cardiologists is that AF is a naturally progressive arrhythmia as well. So probably in most people, when it very first starts, it starts with relatively infrequent episodes of AF with a duration that is relatively short. And then over time, and time is normally counting in years and decades, but sometimes it is quicker than that. But the AF will generally progress so that the episodes get longer, the episodes get more frequent. And then if we still do nothing at all, at some point, the AF will stop being what we call that paroxysmal stage where it spontaneously starts and spontaneously stops. But one day the heart will go into AF and it won't spontaneously come out of it. And it's become persistent at that point in time. And that progression is going to detract from our ultimate ability to control the arrhythmia. So it is definitely better to have intervention done upon AF earlier rather than later when it is what a patient wants to have done.
Wonderful. So is there a choice when they have an ablation? Are you allowed to choose which type of ablation, such as the pulse field?
So I don't think you're necessarily allowed to choose, because a lot will come down to a center and its experience. But I think it is probably worth knowing some of the differences between ablations. And this slide shows two of the most commonly used ablation modalities for AF that we've had up until very recently. On the left is a sort of a diagrammatic representation of radiofrequency ablation, where we come up from a vein in the leg into the right side of the heart, cross over from the right side into the left side, and then within the left side we are using a very agile, mobile point-by-point catheter, and each spot that we want to target, we deliver a radiofrequency current that heats up the tissue, and that results in the ablation effect. And we play a join the dots game where we place lots of dots around the things that we intend to target with an ablation. Then the next technology that became available was really the cryo balloon, and this is also a very effective tool in the right hands. Same principles, in from the vein in the leg, up into the right side, cross over to the left. But instead now of using a little 3.5mm tip metal electrode that we heat up, this is typically a 28mm balloon that we just inflate, push up against the target, and then freeze the whole vein in one go, rather than having to do little dots all around it. And again, can be very effective. And both of those have been used for quite some time.
Mm-hmm.
The latest change to that really is the pulse field ablation. And the reason why people were looking for a different technology is because cryoablation and radiofrequency, both of those are what we would call thermal ablations. So they rely on temperature changes to create the intended damage to the heart muscle tissue. And every cell in the body is ultimately going to be susceptible to damage from a temperature extreme. So within our chest, surrounding the heart, there are other structures that are not the heart, and we don't really want to ablate at the same time. And so when we undertake any form of an ablation within the heart, we have to be very mindful of what are the nearby surrounding structures that are nothing to do with the heart and are not our intended targets, but have the potential to be injured or ablated completely with any of our energy sources. And because the thermal ones of radiofrequency and cryo can certainly spread and injure other things, that has been the largest Achilles heel, if you like, of the technologies, is we have to be very sensitive of what's nearby and what we don't want to damage. And so then the advantage of pulse field as a technology predominantly comes from the fact that it's a different form of energy, essentially. It's still electrical, in fairness, but delivered in a very different way, that the injury that it creates to the target cells isn't by a temperature change. It's by a very large electrical pulse that essentially punches a hole in the membrane of a cell, which is why it's called electro or proliferation, because pores, little channels form in the cell membrane by the delivery of the large electrical currents. And so that is what results in the intended cell death. And by almost a quirk of biology, it happens that heart muscle cells, because of their size, their shape, their metabolic activity, different properties about them, mean that they are actually exquisitely sensitive to the pulse field ablation energy source in terms of being damaged, which is what we want to achieve. Whereas fortunately, the nerves, the esophagus, the food pipe, the lungs, all of the surrounding structures, whilst they still can be damaged with pulse field, they need an awful lot more energy from the pulse field to do it. So the safety margin between in damaging the intended target but nothing else is much better with pulse field ablation. And so it appears, and so far is borne out, to be a safer form of technology. So there are some definite advantages to pulse field in that regard. And that's not to say that the other technologies are not very good, because I think the other thing it has to emphasize is that what matters more in terms of the success and outcome to a patient is going to probably be the familiarity that their consultant has with a different technology. So if you take someone who's never used pulse field ablation before, but is an expert with 20 years experience using a cryoballoon, then I don't think they'll necessarily do a very good job on their first case with pulse field ablation. Far better that they can, they were going to get a better outcome with using cryoablation. But if you have a completely level playing field and you have a consultant who's used all technologies and used them all extensively, then there are definitely advantages, both theoretically and seeming to be borne out, with pulse field as an ablation source. It has one minor downside, which does get in the way, particularly in the United Kingdom, is that at the moment, the energy requirements for pulse field ablation are quite large, which basically means it's a lot of volts being applied in a very short period of time, which basically means it hurts a lot if patients are awake. And so it is a procedure that has to be done under either very deep sedation or, essentially in the UK, under a general anaesthetic. It's absolutely fine. It limits its ability to roll it out a little bit, because not every centre has as much access to having anaesthetist present for an ablation. And so that's why there will be variation within the country about which centres do and do not have pulse field ablation technologies available to them.
Okay, so you've kind of outlined it's very effective, it's going to be very popular, and you feel that it might be the one ablation, because it's so targeted, that will be the best one for the future. But it is something that you would have to go under general anaesthetic for, as opposed to sedation, because of the pain barrier. What about recovery? Lots of people recover from different procedures at a different rate. How would you say that the pulse field ablation would vary from, say, the cryo or the other alternatives?
That's a good question as well. So I think, in fairness, and as you say, everyone is different, everyone's pain threshold is different, and everyone's ability to recover is different. But at Papworth, we would certainly undertake all of these ablations, regardless of the energy source, as a day case procedure. So we expect people to be well enough a few hours after the procedure that they can go home. So that isn't different between whether we choose to use radiofrequency or cryoballoon or pulse field. What is definitely different from a patient's perspective is the sort of the amount of discomfort they have in their chest afterwards. It's very normal with cryoablation and radiofrequency for there to be an element of chest discomfort afterwards that probably tends to peak around 3 or 4 hours after the procedure and can be reasonably significant in people. And I wouldn't want to understate it, even as a doctor, when we say this won't hurt at all. It can be definitely uncomfortable, variable from one person to the next, but can definitely be uncomfortable. And over the next 24, 48 hours, generally would expect that to dissipate. The interesting thing, another interesting thing about pulse field is, because the mechanism of which it injures cells is different, the response the body has to that ablation is different, and we see a lot less of the inflammation after pulse field ablation, which basically, from a patient's perspective, translates into the fact that actually they have very little, almost no discomfort in their chest after the procedure. Plenty of them have woken up and asked me, did we actually do it? As the question comes, I can't feel anything. Did you definitely do something? So that definitely is a very positive from a patient perspective, is the recovery afterwards is substantially quicker from the chest perspective. As far as the vein is concerned, where we access everything, it's the same because it's same size tubes pretty much and everything else. So that aspect of the recovery afterwards is not going to be any different.
Oh, that's good to know then. I was interested to know. I was worried. Lots of people have the blanking period. So with all the other ablation procedures, once the blanking period is over, are they likely to experience the same side effects afterwards?
So the blanking period is an interesting thing, and if patients are not aware of it, then there's this phenomenon that historically we have accepted that going into the heart, delivering lots of energy and ablating lots of tissue, and the concomitant inflammation that accompanies that can result in decided electrical irritability in those atria, i.e., people will get AF in the first few weeks after an AF ablation, not uncommonly, and it doesn't mean the procedure hasn't worked, but it's not great from the patient perspective to get that AF because they're like, oh, this is annoying. I'm still no better at the moment. That ablation, that inflammation typically then settles, and then they will often go on to get the good outcomes from the ablation. But it does mean the first 2 or 3 months can sometimes be a little bit more bumpy. The advantage theoretically with pulse field is that seems to be less of an issue. That because there's less inflammation, there seems to be less of arrhythmia burden during the blanking period. It's still early within the sort of trials afterwards to be definitive about it, and we still pretty much take the same approach in terms of advising patients. Say it might happen, you might get some arrhythmia after the ablation. Doesn't mean it hasn't worked. We just keep the drugs going, cross our fingers, and wait for it all to settle down. But it does also seem that the pulse field results in less inflammation, so less of an arrhythmia issue in the blanking period. I don't think we're going to remove that period for the time being from a clinical perspective, but it is another advantage to the technology, definitely.
Okay. Also, it's not unknown for some people to have a repeat ablation. Is this more likely to not require a repeat down the line, or is it no different?
So I think independent of the introduction of the pulse field technology, the ablation has been getting better and better for AF over the last 10 years in terms of reducing the repeat procedure rates. There have been lots of studies on how to minimize that repeat procedure rate with radio frequency and with the cryo balloon as well. And I would say in good experience centers and good hands, the procedures now, whether they're pulse field or whether they're radio frequency or cryo, are going to have reasonably similar clinical outcomes. And that's what the most recent clinical study would say, is that there's maybe some nudging ahead in terms of superiority of the PFA in terms of success, and that is going to be about the durability of the lesion. So the less requirement for repeat procedures and the reduced arrhythmias occurring early afterwards. That does seem to be that it is a nose ahead in that sense. But the other technologies have also gotten considerably better as well. Because I think it is important to know that their cryo and RF are still very, very effective in the right hands as well. But one is hoping and thinking that pulse field is going to have another step forward in reducing the recurrent ablation needs. I think probably what will make a biggest difference on that is actually electrophysiologists meeting patients much earlier within their AF history so that we can have the conversations about ablations, and where patients would like to take us up on it, we can get them done earlier, because I think that more than any technology change will probably make the biggest difference on the outcomes from ablations, is being able to ablate paroxysmal AF earlier and making it less likely to progress to persistent AF as well, where we know the horse hasn't completely bolted at that point, but it's getting close to bolting.
So get it done as soon as possible. If you've been recommended to have one, grab it.
Yeah. And within that, the important thing is an AF ablation still is, as fancy as all the technology is not being shown to make anybody live any longer. This is about symptoms and quality of life. So nobody should ever think that they must have an ablation. It's not like a malignant melanoma, which we must remove, otherwise bad things will happen. This is about symptoms and balancing up with that patient individually about what are the risks of the intervention and treatment that we have to offer against how much is an arrhythmia impacting on their quality of life. And I think the important thing is that patients, wherever possible, should have access to electrophysiologists, access to experts who can explain all of those and have that conversation with the patient so they can make up their mind. But I think it should always go back to the patient as being their choice, but they can only make that decision once they've had that conversation.
Absolutely. So if one of the patients wanted to go ahead and have an ablation, particularly the pulse field, and the GP's never heard of it, are they able to go somewhere and find out a bit more information? Will the GP know where to refer them? Or is it just they have to stay within their health authority and stay where they are?
So as far as I'm aware, still within the NHS, you can, in theory, take your care any way you would like to take your care within the NHS. And that has been written into the patient charter for many years. So unless someone goes around and changes that, that is still present. Pragmatically, a lot of people don't necessarily exercise that right. And that's fine, because a lot of the time they get excellent care nearby, and clearly geography, it makes logistics a lot easier. Basically, pulse field, well, ablation, I think the first step a patient needs, if they're still only at the primary care level of interactions, is they should ask to be referred to an electrophysiologist, to a rhythm management specialist team in their closest hospital, if necessary, as a starting point, so that they can have those discussions. And the GP certainly should know where the local electrophysiology department is, because it will be an extension normally of a cardiology department. Not every smaller district general hospital will have electrophysiologists. We are an odd beast, that we do tend to be concentrated more in the larger, what are called often tertiary referral centres, or much bigger district general hospitals, because ablation technology is fundamentally very expensive, and it's not available everywhere, and nor should it be, probably, because the expertise is better concentrated in smaller areas to get better outcomes for people. But within a local geography, a GP should certainly know where their arrhythmia management services are from that perspective, and that's a good starting point. And that way the patient will get an idea of whether an ablation is the right thing for them, whether the outcomes for them are going to be good or medium, depending on their comorbidities, their AF type, etc. And then they can also establish whether or not they're locally pulse field, if it is something they passionately want, is available or not available. And if it is not, they are fully entitled to get referred to a centre that does have it.
Wonderful. So just to summarise, Dr. Heck, everything that you've discussed this afternoon has been fantastic and it's very informative. If you are offered an ablation, definitely go for it. It's a very good, highly successful treatment option for AF, although we know there is no permanent cure. Is there anything else that you'd like to add to that?
No, I think that's fair. I think as long as they've been seen by sensible people, if we offer an ablation to patients, we are normally doing it because we think there's a reasonable probability of success. And obviously, patient choice. The patient is the only person who knows how their arrhythmia intrudes on their quality of life. No one else can make that judgment for them. But as long as they're armed with the appropriate information about the pros and cons of the offered intervention against their symptoms, then absolutely, if someone's bothered by their AF, I would have a very low threshold for always offering an ablation in the right patients, because done earlier rather than later, the outcomes will be better, more likely to get good control of their arrhythmia. And in parallel, always nagging gently about the lifestyle factors that are incredibly important as well, because we know we just do our bit and nobody does their bit, then the outcomes will not be good. So it is very much a team affair that comes together to make the control of their arrhythmia better. But absolutely, if we could offer more ablations to paroxysmal AF patients who wants it, then we will have fewer persistent AF patients, and so that becomes less of an issue. So definitely earlier rather than later if people want ablation. And people need to know that ablation exists in order to know whether they want it or not. Definitely.
Thank you.